surgical valves, are there gender differences?
Okay. Assalamu alaikum jami'an. First of all, I would like to thank the organizing committee for the invitation. Hopefully my talk will summarize the previous two speakers' talk, or be an adjuvant, and it will be the surgical point of view. My talk is about surgical valve. Is there a difference in gender? First of all, I'd like to state that I have no disclosures. I would like to start with a case. One of my colleagues, as a cardiologist who's taking care of the antenatal cardiology clinic, talked to me about a 26-year-old female. She had partial AV canal when she was a child. She had a surgical repair for it, and then developed over time progressive mitral regurgitation, underwent tissue valve replacement at the age of 17, and 5 years later, this valve degenerated. She had a mechanical valve, and then now she's pregnant. His concerns was mainly regarding the anticoagulation and also the risk of thrombosis. We had a bad history with patients who get pregnant with mechanical valve with thrombosis. When you talk about the type of valves for women, the guidelines doesn't help us much. It tells you the difference between when to use a mechanical valve, when to use a tissue valve, but there's no specific things about the gender. Also, it's important to remember that valvular heart disease is different between men and women. Actually, women have worse outcome, and most of these women have rheumatic heart disease. They are older. These women, their symptoms are not diagnosed early on. The diagnostic characteristic in echo are not in tone to women. They're mainly to men. They have to be indexed, so this is why these patients are referred late for surgery, which results actually in a bad outcome. The scores that we use for surgery when we want to plan surgery and assess the risk are consider being a woman as a risk factor. And this was actually validated by the Euroscore 1 for women who had to go under a TAVI for symptomatic AS, and it predicted correctly the one-year mortality and stroke. So it's important to remember that women are getting older. The population is mainly women, actually, and valvular heart disease is more common in women than in men. Also, especially in aortic valve stenosis, the fibrosis of the valve is not calcified. In women, there's fibrosis rather, so the diagnostic tools that you use might not be very predictive of the stenosis. If you look at mitral valves, the echo dimensions that we look at, it mainly for men, they're not for women. For women, you have to use the body surface area, and they're not indexed. So these women are delayedly referred for surgery. If you look at the surgical gender differences affecting the outcome of the valvular surgery, in aortic valve surgery, as my colleagues talked about, that the annulus in a women aortic valve annulus is smaller, so they are more prone to have a patient prosthesis mismatch. Also, they have higher risk of developing stroke after valve replacement compared to men. While the mitral valve, they are less likely to have a repair because most of their etiology of the valve is rheumatic, which is less likely to be repaired. So they get the short end of the stick. And if you look at the in-hospital mortality in patients who undergo left-sided valve surgery, women also fare very badly compared to men. And that is, as I stated again, I want to say again, is that women are compared, when you are preparing them for surgery and considering them for surgery, it's like men. And we have to know that they are not. Their echo baseline characteristic is totally different. They have a smaller volume. They have smaller effective orifice area. So these things need to be considered, and these have to be included in the guidelines. So when you look at them, these patients will have poorer quality of function. They will have poorer outcome of surgery because of the delay. The other thing also is women, although if you look at mitral valve, the repair of mitral valve is the best type of treatment. Men do very well because their type of etiology is totally different. It's degenerative and maximatous, and it can be repaired, and they're referred early. While women, Their repair mainly is due to either degeneration with calcification or even rheumatic, and which repair is not that good. But they actually do better than men in replacement. And I said, and I have to reiterate again, it's because of different etiology, maybe. In a editorial published by Nina Marzan, she was talking about the bias in mitral valve disease in favor of men. And she had some consideration and thought that this bias could be due to the type of procedure that's being offered to women, which is replacement. And I had explained to you now why most of these women end up with replacement. And also that these women that undergo mitral valve surgery are older than men. And they have a lot of comorbidities. They have other diseases like COPD that can be misconceived to be cardiac. Also, so how to avoid these type of biases when you have a patient who has a mitral valve disease? First of all, we have to be aware. We have to make sure when you have a patient with possible mitral valve disease and you're considering referring this patient, you have to have a very careful history, more construed test, and risk stratification for these women compared to men, and you have to have a close follow-up. An earlier referral for repair and or even surgical replacement is a lot better for women. This is another paper which just tells you how bad women do with surgical aortic valve replacement compared to TAVI, as my colleague mentioned earlier on. And their outcome is not that good. And the reason being that these women are elderly, they have a lot of comorbidities, they are referred late, and we have to wait for complications to happen, and they have a lot of comorbidities. So this is the reason they do a lot worse than men. Most of these patients also could have a lot of surgeries before. And of course, we need to talk about infective endocarditis. Patients who have a valve surgery, even women do worse with infective endocarditis because when you refer these patients, you refer them late, they have a lot of complications, they will have heart failure, and don't forget the technical issues because of the small annular, especially if they have aortic valve disease. And then we have to think about, we have the younger ladies who wants to get pregnant, and like the patient I just mentioned earlier on in my talk. And you can see that this patient, you want to know, is bioprosthesis good for young women or mechanical? And in this study done by Singap from Egypt, they looked like that the 10-year follow-up, young women actually did very well with bioprosthesis. And of course, the tricuspid valve, as surgeons, we try not to forget it. This is one of the most important valves because it has a high morbidity and mortality. And actually, the symptoms are very subtle and very slow. It's common in women, okay? And actually, these women have symptoms that they ignore. And the cardiologists who are seeing these patients are not aware how bad it gets in some of these cardiologists. So if you refer a patient to surgeon, by the time they're referred to us, they require replacement. And a replacement is a lot worse than a repair. Because once you go to a replacement, you have RV dysfunction, you have pulmonary hypertension, so their morbidity is very high. And then we're talking about the pregnancy and mechanical valves. There are a lot of people who want to avoid bioprosthesis because once we tell the patient the type of valve you want, they will tell us we don't want to have another surgery. So most of these patients, they want to have mechanical valves. And like the patient I just presented earlier, they have a mechanical valve. So what are we going to do about it? This is a pilot study, and actually it involved a small group of women, which is 60 women. It's just a representative of the dilemma that the cardiologist will have. And about 21 of them had 30 pregnancies. The age was 22 to 53, and they all have a lot of different outcomes. Only 7 live births. The rest was stillbirth, they were abortions, and it didn't matter what kind of a regimen for anticoagulation they used and which level and which trimester. The outcome was that good. So the authors stated that It doesn't matter what kind of a regimen you will use for anticoagulation during the pregnancy, the outcome is actually non-predictable. So I hope you understand that the future of valve replacement is a tissue valve, because most of our patients, they want to avoid anticoagulation. Anticoagulation needs frequent visits to the doctors. They need restriction of food, restriction of activities. We have a lot of young population for the time being. So a lot of companies are looking into some kind of a tissue that will not degenerate and calcify with time. And this promising tissue is called Resilia. They're doing studies on it, the resilience trial and the Endura registry. They've been doing it for the last couple of years. It has good hemodynamics. It's the same tissue valve that we're using actually now, but the material is a bit more resistant to calcification. And hopefully it's promising, and hopefully it will be the solution, we hope. So once you have a patient and you want to give them the best valve, we talk always about the best valve. What are these best valves? The characteristic, the valve has to be durable. It has to have excellent hemodynamics like the normal valve. And also it can be either percutaneously or could be surgically, but percutaneously would have been better because patients don't want to have their chest open. And also they want to avoid long-term anticoagulation. Also, they like to practice their life normally. The other also, also women need to get pregnant. I wanted to end to say a fact that we need to remember. Gender differences has not been the focus of studies in cardiovascular devices. And I think this is a time for it to change. And most of the participants are males. They constitute 70 to 80%. Women are just a small portion. And the outcome of these studies are not powered for significance. The take-home message that I want to convey is women have a higher operative valvular risk factor, risk of mortality and morbidity compared to men, 2 to 1. It remains unclear if female gender is an independent risk factor for these morbidities or mortality, or is it just a sign of other factors that we need to look at. We need national and international awareness campaigns to identify the genuine differences between men and women in valvular heart disease and surgical outcome. And it's important to address the delay in referring women for surgery. Thank you very much.
Thank you very much.